Hi, this is Dr. Lorenzo Albawa. I am going to be talking about cardiac ultrasound today in the final lecture of our point of care ultrasound fundamentals course for emergency medicine providers. Thank you to Dr. Noor Al-Jaboud for providing this lecture for us, and I'm excited to get into it with you. So first, we're going to talk about the sonographic technique. Where do you put the probe? How do you orient it? How do you orient it? And the anatomy that we expect to see in each orientation of the technique. What are the specific questions that we're looking to answer when we do a transthoracic echo in the emergency department? Some of the pitfalls, and we'll have a summary at the end. So let's start off with a case. We have a 54-year-old guy. He's got a history of valvular cardiomyopathy and a cardiac transplant remotely, as well as a history of hypertension. He comes in with chest tightness, shortness of breath for about a week. His vital signs are, as you see here. You're handed an EKG on arrival. So you take a minute to look at that and you start wondering, he's got some possible structural things going on. The EKG looks a little interesting. Why don't we maybe take a look at his ultrasound? What is his heart doing? So first, let's talk about the sonographic technique. When you do a cardiac ultrasound, the best probe to use is your phased array probe. It's even called the cardiac probe sometimes, and it looks like this. It's got this sort of rectangular profile where the sensor is arranged. You're going to have a few locations for taking your ultrasound. So here's a diagram of what you're going to do. In emergency medicine, our typical probe location on the screen is on the left side. And when it is in that location, I like to tell everybody that is learning transthoracic echo, just put the probe marker at the 4 o'clock position. Say there's a clock on your left chest, and imagine 4 o'clock, that's your first position, and that's going to be your parasternal long axis. And then all you need to do to get the short axis is rotate 90 degrees. And so that's in that diagram. That's what you're seeing with those arrows. And then you just slide around to get to the other spots. So we'll get into more of that in a second. So your first view that you try to get is your parasternal long axis. And what you're seeing when you put your probe marker at the 4 o'clock position is this view of the right ventricle up top and the left ventricle on the bottom. So remember, what is higher up on the screen is closer to the probe. So the right ventricle is closer to the chest wall, and the left ventricle is posteriorly. You also see the left ventricular outflow tract and your left atrium. All you need to do once you have the screen sort of, if you imagine a midline centered around your mitral valve, is you rotate 90 degrees clockwise, and you get a short axis view. It's basically like a cross section. You cut the heart short ways, short axis. And this gives you your left ventricle on the right side of the screen and your right ventricle on the left side of the screen, kind of as you see in the diagram. From there, you just drag the probe down to kind of the nipple area in men, and you flatten your angle. So what I mean by flattening your angle is you lower the probe so it's closer to the skin. And that helps you get your your subxiphoid, or I'm sorry, your apical four-chamber on the bottom right of the screen here, where you try to get sort of a cross section of the heart this way, where you see all 4 of the chambers. And then you drag your probe towards the xiphoid area, like the midline, and point up into the chest to see it, to look at the heart through the liver as an acoustic window. So have no fear, we're going to get into each one of them right now. So this is just a bigger view of that parasternal long axis. Again, here use your right ventricle, left ventricle, and this is your entry and exit into the left ventricle seen here. This is the sort of view that you want to get. This is what you want to, it's all about pattern recognition, right? So when you see this pattern, that means you've gotten the right view. Okay. So here you can see, I like to have use a clock. So that just makes sense in my mind. But if you want to angle it to, your probe marker pointing to your left elbow, that's another way to think about it. And so this circle here, this is your descending aorta. So that's how you will know if there's an effusion inside your pericardium, is you'll have fluid in here, and a pleural effusion is fluid around it. So that's just something to keep in mind. Peristernal short axis, as I mentioned, it's the cross section after rotating the probe 90 degrees. You should get a nice circular profile in a normal left ventricle. And this is the best view to be able to assess your ejection fraction and if there's any wall motion abnormalities. And so here, your probe marker is 7, 8 o'clock, 90 degrees from 4 o'clock, right? Or your right hip. It's another way to think about it. So when you turn 90 degrees, sometimes you get a cross section a little bit higher, a little bit lower. This is a little bit higher, so you're actually seeing your right atrium, right ventricle, right side of the heart, and left atrium. So if you drag the probe downwards, towards the hips, you'll start to see, your classic two ventricle arrangement. So in this view, your apical four chamber, this is going to be really good to compare the sizes of your left ventricle and your right ventricle. And so this is sort of the anatomy that you're looking to get when you drag the probe down. You don't change the rotation, so you're still at that. Remember, you've rotated. It's like a dance. So you start peristernal long axis, then you do 90 degrees to your short axis, and you keep it in that orientation, but you just drag the probe towards the patient's left hip, and then flatten your angle to get the view of all four chambers. Another way to think about it is keep the marker pointed to the patient's right side. It's really important to get the orientation right. So if you always do the same dance every time, you always get the same orientation. Because if you get the wrong orientation, you might flip the ventricles and get confused. So this is the sort of anatomy that we're looking for here, all four chambers. Your subxiphoid view is the fourth component. Now you're just moving the probe more to the midline. And people don't really get actually how much pressure you have to put in sometimes here. It's kind of uncomfortable for the patient, but I like to take my hands and change it to an overhand grasp. So in this image here, the person is not doing that, but if you flip the hand over top of the probe, you can flatten the angle of the probe even more and kind of push it so it's looking under your xiphoid process at the heart through the liver. So if you look at the image, the top here is your liver. Next to the liver is your right side of the heart, right ventricle, right atrium, left ventricle, left atrium. So marker still facing the patient's right side. So when you're doing an echo, say you want to get a really quick view, you can get two views. That's okay. That'll get, your basic idea. Is there some sort of big pathology? You really want to try to get all four views to be really complete and get a good idea of what's going on. And so the questions that we're looking to answer is there a pericardial effusion? What does the EF look like? And is there RV strain? Is the right ventricle blown out and gigantic compared to the left ventricle? We're not using focus to look at wall motion abnormalities. We might be able to comment on them, but that's really not our job. That's not what we're trained to do. It's only when it's like very obvious that it's hypokinetic. Sometimes we can, think about it, but I would say no commenting on the masses of vegetation, because at the end of the day, the real comment on that comes from transesophageal echo and kind of more dedicated ultrasonographer evaluation of the heart. We're getting these three main questions answered. So, yes, no, is there fluid around the heart in the pericardial sac? What do you guys think? These are two different hearts. So if you said yes to the one on the right, you're correct. That stripe of hypoechoic area around the heart is fluid. You can see kind of the heart almost kind of bouncing around in the pericardial sac. And as I mentioned before, you see the descending aorta, and there's fluid in between the descending aorta and the heart, and that suggests that it's a pericardial effusion, not a pleural effusion. Okay, so again, pericardial effusion, yes or no? I would say on the left, we're pretty good. I'm not seeing anything that looks too suspicious here. You got your liver at the right side of the heart. I'm not seeing any stripe of fluid. On the right side, if you said there's a pericardial effusion, I would say you're 100% correct, and it actually looks quite concerning, because you're having this collapse of your right ventricle, because that fluid around the heart is accumulating to the point that it's compressing the heart and impairing the diastolic filling of the heart. That's what tamponade means. And so the best view to look for a pericardial effusion is your subxiphoid view, because it's usually a dependent fluid collection. This is an example of a pendulum heart where there's so much fluid that the heart is just literally bouncing around in the pericardial sac. And this is when you see that EKG finding of electrical alternans, when your heart is just kind of, your EKG is moving around essentially, and that's because your heart is literally bouncing around in your chest. So what are the signs of tamponade that we look for when we look at, is there RV collapse and RA collapse? So basically, is your tamponade, as your pericardial effusion, so pressurized that it's collapsing the lower pressure side of your heart, your right side of the heart. And as a consequence of that, it's causing your IVC, your cardiac inflow, to be plethoric, because it's not allowing that fluid to return to the heart. You can imagine how this is physiologically problematic. Okay, so pitfalls, sometimes we look at the heart and we're like, is that a stripe of fluid? And in this case, it kind of looks like there's a hypoechoic area, but you can see that it's there's some mixed fluid, and it doesn't really change. The other part that you want to think about it is it doesn't wrap around the heart, doesn't wrap around the apex of the heart. This is actually a fat pad, anterior pericardial fat pad. It's not fluid. This is going back to what I was talking about earlier. You have to look at your descending aorta to be able to clearly determine this. And on the left side, you see that there's fluid in between the heart and the descending aorta, consistent with a pericardial effusion. On the right side, you have a very sad-looking heart with a descending aorta, and there's some fluid outside of that that is a pleural effusion. Another pitfall to keep in mind is don't always expect completely clean hypoechoic, as in just a black stripe for fluid. Because sometimes if that fluid collection is blood, it can clot, especially if it's a little bit older, and it actually looks like this. This is a bunch of clotted blood in the pericardium with a little bit of hypoechoic stripe there. So be careful when you're looking at that. Ejection fraction. we're here to look at, say, big idea. We're not here to give an exact number of the EF. One way to get an idea of your ejection fraction is to actually look at the mitral leaflet and see how close it is to coming to touch the septum. So in a normal, healthy heart, that mitral valve comes right open and all the heart comes through. And that, looks like a normal EF in this heart. And so when you take a look at the cross-sectional view of this normal heart, this is what, a normal looking ejection fraction looks like. All the sides of this concentric circle are thickening as they contract pretty symmetrically. And the area inside is getting smaller pretty symmetrically as well. So that looks like a good normal ejection fraction. So that's pointing to the mitral valve leaflet. That's pretty much tapping the septum there in a normal heart. We'll skip this for now. This is basically measuring, how close that mitral valve leaflet gets to your septum. This is something else that you can look up. It's called your EPSS. And that's using M mode to assess for how close it gets. And you can actually physically measure it. And so less than 7 millimeters equals normal. Hyperdynamic heart. This, you can see the heart's basically contracting almost till it's empty. So you could see this in somebody who has sepsis, like pure just dilation of their blood vessels, and so their heart's working really hard to pump that fluid, or maybe hypovolemic shock, where the heart's working really hard, squeezing everything it's got to get the blood out. So this is an example of a decreased ejection fraction. You can see that mitral valve leaflet doesn't come as close to the septum as we saw before, especially, and you can see that especially on the right side here. So this is a decrease, and again, broad strokes. We're not saying exactly how much percentage EF. We just say normal, decreased, severely decreased. This is a severely decreased ejection fraction. You can see that it's basically just the valves moving, but the rest of the heart is barely contracting at all. So say somebody is getting CPR, we're in a code situation, you're doing a pulse check, and while you're checking for the pulse, you put the probe on the subxiphoid area to look at the heart, and this is what you see. This is cardiac standstill, no cardiac activity. It's not a good sign. One of the situations where you have to be a little bit careful about looking at that mitral valve is if the patient has mitral stenosis, then obviously the mitral valve leaflet is not going to be flapping against the septum as normally. Although in this case, the patient still has a pretty good EF. The heart is contracting okay. So just keep that in mind. The third question we're looking to answer is there strain of the right ventricle? So the best way to assess this question is through your 4-chamber view, because that's going to give you a nice cross section where you can see each ventricle next to each other. You try to get the cross section where they're both of them are as large as you can, so you're not getting kind of like an oblique cross section, and you want to try to get your septum in the midline of the screen. So first, a normal view. And now here is something a little less normal. So look at the one on the right side. You're looking for a left ventricle that's bigger than the right ventricle. That's a normal situation. Should be a little less than 1-to-1, right? On the right side of the screen, I can't even tell which one is the right ventricle, which one is the left ventricle, because they both look so big. In fact, the one on the left side of the screen looks even bigger than the right side of the screen. So that's a dilated right ventricle. and you comparing to the left side of the heart. The left side of the screen, again, is your normal as a comparison. One other thing that you can do, this is a exercise that you can try, is a TAPSE. This is a little bit more advanced, so you can draw a line with M mode through the tricuspid annulus. So you need to get a good view of your right side of the heart here to be able to do this. And you basically see the way that the annulus moves up and down. And so M mode again, so you're seeing, how that tricuspid annulus is moving throughout systole and diastole. And you see, the maximum distance. If you're not having that much movement, that means that there's too much pressure in the right side of the heart, and it's not actually able to work as well. And so that is suggestive of RV strain. And again, why are we looking at this? This is maybe to look for pulmonary embolism or pulmonary hypertension. See, it's not very specific. We don't know exactly what's causing that RV strain. So it's just a tool to use. You can't say for sure, like, oh, there's RV strain, there has to be a PE. This is if you highly suspect a PE and you also see this, then you're like, I think my CT pulmonary angiography is probably going to show me something. It's probably going to show a positive finding. This is an example, very rare. I've never seen this before, but it'd be kind of cool to see of actually you see that. Oh, let's see here again. See that little thing ping-ponging on the left side of the screen, that little white, looks like a ghost that's ping-ponging in and out of the valve. That's actually your clot. That's a piece of clot that's kind of bouncing back and forth. That's kind of cool to see. Another sign of RV strain is when, instead of having a nice concentric, nice circle-shaped left ventricle, there's so much pressure on the right side of the heart that it's pushing the left ventricle. The septum is flattening it, and so it actually looks more like a D rather than an O. That's what you're seeing on the right side of the screen. This is a pretty profound D sign here. Okay, so this is what I mentioned before. Be really careful about not flipping your probe orientation, because you could think that, oh wow, our right ventricle is huge compared to the left ventricle, but this is actually because the probe marker was flipped and you're looking at it the wrong way. And so make sure that your probe marker is at the right side. So back to the case from the beginning, the cardiac transplant patient with a history of hypertension as well. So this is a 4-chamber view. This is a parasternal long axis view. So we're seeing here a little bit of Doppler. The operator put some Doppler on the image. See if it plays. And you can see this jet that's kind of pushing back into the atrium. Looks like a little bit of regurgitation. We'll go back here. Hold on. Now you look back at that valve a little more closely, and you can see this valve leaflet just kind of swinging in the breeze. So sudden onset, shortness of breath, chest pain, with a significant amount of regurgitation seen on the Doppler view of this parasternal long axis, and some ischemic findings on the EKG. You have to be concerned that there's ischemic damage to that papillary muscle, and this has ruptured and caused acute mitral regurgitation. So that's just like a fun case example. But there's, again, we're looking for We're looking with the phased array probe, at least 2 views, and we really want to get all 4 views. And we're looking at the ejection fraction. You want to get an idea: is it normal, depressed, severely depressed? Is there cardiac standstill? A bit broad strokes here. Is there an effusion? Yes or no? Is there tamponade as a result of that effusion? And what does the right ventricle look like compared to the left ventricle? So we can look at the parasternal long axis for a good estimation of the ejection fraction. Apical 4-chamber is really good to look at the RV compared to the LV. And your subxiphoid view is the best when you're looking for an effusion, you're checking for tamponade. And you can use that descending aorta to help you determine where that fluid actually is. And that's all. I hope that answered some questions about transthoracic echocardiography. Please reach out to me if you have any questions at all, and I look forward to scanning with you next time.